Well, good evening once again. As we mentioned, tonight we're going to be looking at matters public health. And on the shift, as we mentioned, we get into the heart of the matter to discuss the realities of public health. What is thriving, what needs diagnosis, and what is a prescription for a healthier nation. So joining us tonight on set to dissect these critical issues is none other than Principal Secretary in charge of Public Health and Professional Standards, Mary Muthoni, who is at the forefront in championing the government's policy on preventive care. Good evening once again. This is The Shift, and I am Regina Manyara. Welcome, ma'am, and thank you very much for your time.
Thank you. Thank you very much.
Now, quick one.
Let's be here.
Good. Now, just let's get to meet you. We'd want to know what has been the most rewarding part of your journey as PS Public Health so far.
I think I am happy to see reduction of the disease burden in the country. I am happy to see people embracing quick wins in terms of prevention, because public health, basically, I summarize it in 3 words: prevention, promotion, and protection.
Prevention, promotion, and protection.
And protection.
The 3 Ps.
The 3 Ps.
On that note,
that's how I would summarize it to any layman.
Any layman.
Prevention in terms of there are things that we can do to prevent diseases. Promotion in terms of telling people what they need to do. And equally protection. You've seen us protect our boundaries and also ensuring that we don't have emerging issues coming into our country. So really, the 3 Ps summarize it much for me. And it's my happiness to see a happy nation. It is my happiness to see people who are able to have intrinsic motivation to do the right thing, and especially to prevent diseases or to prevent themselves from diseases.
The 3 Ps. We'll be tackling it as we discuss matters public here on The Shift. And tonight, in one of the very first, we have a live audience on our venue tonight. That is the Kenya Medical Training College. And those who are seated in the audience today include students who are studying in this particular college. This is a headquarters. Remember, this is a department within the Ministry of Health that is charged with the training of professionals in this particular value chain to feed the local, regional, and international market. We also have principals of various campuses in the house, and they're going to have a one-on-one interaction with our guest tonight to just put into perspective matters of public health. Just the same, you will be also allowed to give in your feedback tonight. You can get us on our various platforms, including X at KBC Channel 1. And tonight we were posing this question to you back at home. What do you think is actually the biggest problem with Kenya's healthcare system? And the choices that we have: choice A, high cost of treatment; choice 2, shortage of medical personnel; choice 3, poor hospital facilities; and last but not least, on D is shift from NHIF to SHA. That's an opportunity for you to interact with us tonight on The Shift in as far as matters of public health are concerned. So you said the 3 Ps, Madam PS.
Yes,
that's a question to the audience. We'll also sample your feedback on that.
I'm waiting for the answer.
We'll get to that.
I'm eagerly waiting for the answer.
You'll give us the feedback. So on a scale of 1 to 10, how would you rate the public health docket?
Wow. I think I would say we are not where we are supposed to be. And for me, it's a continuous process.
Continuous process.
And really, let the work rate itself.
All right.
But I would say we are doing the very best to ensure the interest of the public in terms of public health, and equally ensure that we have reduction of diseases, starting from communicable diseases, non-communicable diseases, and ensure that Kenyans are accessing care at the very best, availability of care, accessibility of care, acceptability of care, and equally affordability of the same.
Madam Pierce, I hear you do not want to give us a scale of 1 to 10, but we'll pick it up at the end of this conversation. We will know where we are between 1 and 10. We'll get back to it. Now, let's talk about universal health care.
Yes.
But before we get to the nitty-gritty details of the universal health coverage, just unpack what happens under the public health docket.
Under the public health docket, we, and especially going by the executive order, our state department is public health and professional standards. And that is why we are here at KMTC today, because we deal with the professional standards, the training of healthcare workforce, both undergraduate and postgraduate, prevention of diseases, as I had said earlier, promotion of health promotion in regards to, I can give an example of probably taking care of yourselves by eating better and ensuring that you prevent diseases by eating well. And really, we are also able to sensitize the masses on emerging and re-emerging issues in society. We are able to go all out, tell the people that your personal hygiene is very important. Environmental hygiene, remember we are talking about issues of climate change, the extreme weather condition, you know, may it be more rain or more heat, it is a danger to us. Again, we have water, issues of water, sanitation. Unknown to you probably, Kenya still has 15 counties that still practice open defecation. And this is a critical issue. Therefore, public health is broad.
It's broad.
Vaccination issues, you know. So it is rather broad, and we are able to cover each and every corner of this country, ensuring that, go back to the 3 Ps, yes. Prevention, promotion and protection.
So now, under the universal health coverage, you know, journey, you've mentioned it's a journey and not a destination. What would you say has been the progress in as far as implementation is concerned?
Look, Kenya has committed to roll out the universal health coverage and to make it succeed. We have tried many times, and this time round, it is not going to be a trial. It is going to be action-oriented. The Ministry of Health, or rather, let me start with the Kenya in general. Under the Kenya Kwanza administration, we have 5 key agenda items, starting with health, MSME, housing, digital economy, and we have agriculture. So you see, health is strategically placed even within the government itself. And from there, when we go to the Ministry of Health, the very first thing out of the commitment to ensure that there is a universal health coverage, we came up with follows that will help us, because a house without a base is very shaky. And the follows were Digital Health Act of 2023. And digital health basically is talks about interrelatability of data. You know, when you walk from one facility to the other, we are able to have your data in the system, and you don't have to keep repeating stories. You know, when you go to see a health practitioner or at any facility. Then we have the Social Health Insurance Financing Act of 2023, which I will delve into much later. Then we have Primary Healthcare Act of 2023. When we talk about Primary Healthcare Act, this is what is holding on to the lowest level facilities, including also our level 1, which is the community health promoter. And you have seen the great work that the community health promoters are doing at the bottom of the pyramid.
All right.
Indeed, the 107,831 men and women have a gadget, a smartphone that they use. It's their tool of trade instead of carrying around books. And it's also part of the digital Health Act, you know, because they use it to collect data. And equally, they have a kit that has consumables. It has equipment to take blood pressure, blood sugar, you know, medicine for worms for young children, you know, first aid kit. So the Primary Health Care Act has also integrated community service within it. Then we also have Facility Improvement Financing Act of 2023. Really, initially we used to have, when we have budgets or when we have grants, you can easily reallocate it to any other agenda. You can take it to roads, environment, or any other. But right now what you're saying, we've anchored it into law, that any money that is meant for health must remain in health. We have basically ring-fenced.
Ring-fenced the laws and the funding.
Sorry?
The funding, as you said, ring-fenced the
We
sector.
have ring-fenced any money that is allocated or granted and meant for health agenda, whether it's for buying commodities or construction or equipping facilities. It can never be reallocated by either the county assemblies or the National Assembly. It will remain in health. So if it goes to the county government, nobody can say there's emergency now, we move this money to this place through the Facility Improvement Financing Act. So that law. Then we also have okay.
The laws. We'll come back to the laws. Now, let's talk about one fundamental issue. You've talked about the social health
insurance financing.
In financing, that is. Now, SHA. Now, with the establishment of SHA as it is to cover all Kenyans, what has been the enrollment progress, you know, especially on the vulnerable population?
Now, the Social Health Insurance Financing Act, which happens to be under the Social Health Authority.
Yes.
The Social Health Authority is just a structure by itself that now houses three funds. We have the Primary Healthcare Fund, which now caters for the lowest level of facilities, that is level 2 and level 3, whereby we initially, people never used to be catered for through NHIF, but right now you can go to level 2 and level 3 without payment. You can be taken care of. Then we have the Social Health Insurance Fund, which takes care of the secondary facilities and the tertiary facilities, that is level 4, 5, and 6. And we also have the chronic emergency, chronic, and critical illness fund. If you look at the number of emergencies that we have on the road or any other, even in your own house, sometimes you may just slide in the bathroom. And initially people would go to the facility and you're told, put a deposit, 20, 50,000, so that we can get a specialist to come and attend to you, and probably you have broken your leg. So we want to run away from that kind of engagement. Now, as at today, we have 20.7 million people who have registered to the Social Health Authority. And indeed, this is a good thing, because NHIF only used to cater 20% of our population. And out of that 20%, majority of them used to be the salaried. That is me and you, you know. But right now we want everybody, 100% registration of every Kenyan who lives here, so that whenever you go to any facility, you're able to access care. And if you look at NHIF again, this is a fund. It was only one fund, and it had existed for 60 years. Now, we are talking about SHA, which has existed for 2 years. And you can see we have 3 funds in it, and we are rolling out. More people are joining in. And forget about what people are saying, oh, few people are a few people are paying. But it is work ongoing. we expect as people register, they are able to pay so that we are able to also offer the very best of the services. Right. Therefore, again, NHIF would also cover smaller groupings of for instance, it would cover students who are in secondary school, as opposed to now SHA that is covering every other child that is in the country. Look at Linda Mama. People would, mothers would just go to give birth, as opposed to now when you are catered for during prenatal or antenatal, during delivery and after delivery. So we have enhanced almost every other package. The other day we had, we were covering hospital bed at 4,000, but now we've already gazetted that we will cover it at 28,000. It is an improvement. So from 4,000
to 28,000,
yes.
It is under gazettement right now.
It is already done.
It is already done.
And that is why I'm saying, let us believe what the government is doing. Because at the end of the day, we will be able to listen to what Kenyans are saying. If they are complaining, we are not deaf. We are a listening government. We are able to go back and look at the tariffs and say, maybe we didn't justifiably give it enough funds to be able to cater for the kind of sickness. Look at oncology. People have been complaining simply because we had put at 300,000, but right now it has moved to 500,000 because we saw the suffering that Kenyans were going through. Okay. If you look at the first week of SHA, there was chaos across the country, and in fact, the people who have who were going for dialysis services across board, they had a lot of problems. But right now, dialysis is one of the
they've delivered
the cases that has been delivered very well.
Okay. We'll pick up on that point on the delivery. Now we will be looking at what do Kenyans say about the facilities in as far as public health is concerned. So we take a quick breather on the shift. Remember, you can be part of this conversation. Get us on X at KBC Channel 1. Yes, it's quite windy here. We are having a bit of, climate change, as we say. But hey, nonetheless, we're going to keep it here. We are here, we're not leaving. We'll have to address matters of public health, so be part of this conversation. See you in a bit. Well, it's windy out here, but we are staying put for the shift as we discuss matters of public health with none other than Principal Secretary in charge of Public Health and Professional Standards, that is Mary Muthoni. And before we took a quick breather, we were looking at what has been done so far, especially targeting vulnerable members of the community there, and just having the rundown on that. So let's pick it up from there, Madam PS. Would want to know, have we contained the spread of Mpox?
Yes, and from where I sit, yes, we have been able to do all, to put all systems together and ensure that there is no much spread. As you have seen since last year, we are still at maybe 50 people who have Mpox, and most of them have healed. And they have gone back home. We have enhanced a lot of surveillance across the borders, the ports of entry. We have been able to train our healthcare workers on how to deal with it. Not just healthcare workers, including the hoteliers and any other people who may be coming into contact with people or travelers who are likely to have the disease. Now, we have also been able to ensure that screening is done at the ports of entry. If you look at an entry like JK, Jomo Kenyatta, we have 24,000 people who go through that port of entry every other single day. And if you probably divide it by 2, the people who are coming into the country could be around 12,000. Therefore, we are able to screen each and every person who is coming into the country, and you're singled out and isolated should you be having that disease. And not just Mpox. In our neighboring countries, we have had issues of Ebola. We have had issues of Marburg. And so our preparedness is not just for mpox, but any other pandemic should it happen.
Now, on that note, yes, since you've said that we are ready and we are doing this screening. Now, I'm just going to use this word with a tinge of salt. Just recently, there was a strange disease. We're calling it strange because we are not in the medical profession. We may be lacking. In Kisii. And it was linked to contaminated water. So how are we, prepared to deal with such outbreaks? And first, maybe you can tell us, we are calling it strange disease. What was it?
Well, let's just call it the strange disease in Kisii.
All right.
But we were able to unravel what exactly was happening. And it was one area, one water point, where the water was contaminated with fecal matter. And because once we took the samples in the lab from the water in the houses and the water from the pipe, the results were the same. And therefore, we were able to have the prescriptions done better for the people who had been affected. About 8 villages had been affected. What we did was to close that place so that the people from that area could get water from another point. And and we also sent our community health promoters together with the national administration to ensure they go from door to door and ask the people to boil their water. And if you're not boiling, then make sure the water is treated that you're taking. Because some of these things, basically, it's out of how we deal with them from a layman's perspective. And that is why when you asked me what is our work, I also said health promotion is part of it. And this we are doing very well with our community health promoters. In terms of screening, ensuring that we are encouraging people to also go for screening for diseases like cancer, so that it can be detected early. Our community health promoters, if I may go on to talk about them, is a great force. We have 107,831. As at today, 29 million people have already been screened for diabetes. And out of that, 340,000 have been referred to a health facility for further assessment. 19 million people have been assessed for blood pressure. And out of that, 744 have been referred to a health facility for further assessment. What does this mean? That most of us are working patients.
Indeed,
we may not know. We may not know. Absolutely.
Then, Madam Pierce, what are you doing to support CHPs who are in security or bandit-prone areas? Because they still have to work. How are you supporting them?
This is their village. This is their space. These CHPs come from their locality. We don't export CHPs from any other area. So whatever is being done in those areas through the national administration and the security team, it covers even our CHPs, just like our facilities that are in those areas. So nothing out of the ordinary, really, because these are people from the community. And each CHP covers 100 households. So those are your neighbors.
Indeed.
It is where you walk as you're going to the market. You have your kit and you have your phone. But we expect them to visit each and every person at any given time. They're supposed to find the women who are pregnant and have not been able to go for their antenatal and tell them that Linda Mama exists so that they can go for their prenatal care. They are supposed to find the teenage mothers who are in their houses, who are hiding because of stigmatization, and tell them that it is important they go for prenatal care. They are actually trained. Our CHPs are trained to actually assess common childhood ailments. They are able to check malnutrition of children. They are able to assess, the common childhood ailments, diarrhea, and are able to guide the mothers and the caregivers on what to do. And already more than 3 million children have been visited by our community health
Indeed, those
promoters.
are good numbers. Those
So
are good numbers.
indeed, part of what I'll keep going back to prevention, promotion and protection. So that just basically to break it down, prevention in the sense that they also have chlorine that they distribute to the households just to ensure this prevention of diseases if you take clean water. And equally, they are able to tell members of the public, come up with your small kitchen garden so that you can have a balanced diet. They are able to ensure they are telling the members of the public, the citizens, that go for early screening.
Okay.
You know.
Now let's find out, Pierce. We'll pick it up from there. We'll pick it up.
You invited me
community
for
health
conversation.
Workers. We have people who are online and they want to give their views, Madam Pierce. Please allow us to have that conversations with Mwananchi. Thank you very much for giving us your feedback. Let's just sample what Kenyans had to say about public health and what they think Madam Pierce Mary Muthoni tonight should address. Let's have a look.
In the context of Kenyan health services, prevention is better than cure. Why? Because treating an illness is more expensive than preventing it. And preventing the illness also leads to an healthier population. But what do Kenyans know about this? Let's find out.
I don't know what is UHC anyway. I have not gotten to any forum that explains UHC to me. So actually I have never heard of it myself.
Hili jambo la universal healthcare mwananchi wa kawaida hajaweza kuelezwa vizuri na serikali, and that is why you can see people complaining here and there that it is not working, because SHA is part of the universal healthcare, and that is to my understanding. And the reason why it is not working is because maybe one of the issues is information. People don't have the information.
Wacha nichukulie kama hiyo SHA ambayo ni part of that universal healthcare change to be somehow like Betika. Kwa nini nasema namna hiyo imekuwa kama Betika? Betika watu wote watalipa, watu 1 million watalipa. Lakini watu wale ambao watasaidika naye ni watu 3 out of 1 million.
People don't have information. Like you can have a public being invited by various institutions, county governments, and health centers, to people to come and screen themselves or check their health status, but the information is not reaching out to the people. So it is not accessible, I can say that.
Sasa kama hii yenye nilikuwa napita tu nikasukia wanasema nini TB natakikana kupimwa. Sasa na mimi nikaona wacha nipimwe hiyo TB nione kama inaweza kuwa niko naye.
Aondoe saa arudisha ile ilikuwa mbeleni.
Like improve healthcare iko affordable kwa kila mtu. Ndio like watu wenye like street people wanaweza afford healthcare juu huku nje si kuna siku safi and stuff, so waweze ku access healthcare.
They should try and improve on the health sector, like without bringing new projects which are costly to the common mwananchi and which are burdening our local people with new taxes.
And even when you look at the services, it is not as way it's supposed to be. So it needs a very, what we can call, very critical look of it to make sure that it is checked to the deep, to make sure that the person in the ground, yule wa chini kabisa, yule mtu wa chini amesaidika na healthcare.
Well, that is what Kenyans had to say in regard to the questions that we posed to our guests tonight. And we want to give you an opportunity to respond to that. Some of the issues that have been brought forth, Madam Pierce, is the lack of adequate information on what is available and how they can access that. Secondly, is that they seem not to understand the dynamics, you know, around the transition now under Taifa Care and such. Then also there's a question that has gotten here on X that is, ask Madam Pierce to address the case of quack doctors and negligence. You know, what measures are in place to enforce professional standards and punish offenders. Maybe you can respond to those three as you continue sampling the feedback.
Okay. Indeed, I must say probably we haven't gone all out on communication, and that is why I am here tonight, because there are many medium types of communication, and this is just one. We should be able to reach each and every Kenyan wherever they are. If you look at the issue of SHA, we have been able to come up even with a call center. That is to make it very easy for people to call, so that you don't keep asking yourself, where do I get help? It is important to also give written communication to even facilities where if anybody goes to any facility, you are able to access information easily. So we will continue with the same. We will continue engaging people like yourself, so that you give us the loudspeaker. You are one mouth, there's another person who can be able to channel the communication, and also through students like here at KMTC, the ones who are listening to me tonight, they will go home with one or two, three things that they never knew about universal health coverage. What Kenyans want are services. Yes. And that is what I have gotten.
Indeed, they want services, and they just don't know about them.
They want services. And that is why we came up with SHA. That is why we even anchored it into law, to ensure it is strong, the base is strong. And that is why we also came up with the 3 funds, 2 of which are funded by the Exchequer, and 1 which is our Harambe.
All right.
That all of us are pulling funds together to ensure that we have better facilities in terms of infrastructure, that even infrastructure, if you go to a facility, even mothers have dignity in not giving birth in an open hall, to make sure that we have equipment, and the right equipment in our facilities, to make sure that we also have human resources in the same facilities, and also to make sure that people can access these services and afford them easily.
Now, Madam Pierce, you've mentioned something.
There's a question.
Yes, on competency.
Quality of care.
Quality of care and the competency.
And of the quack doctors.
Yes.
That is what you're asking.
Yes.
Kenya is very key into equipping the human resources for health with the best skills. And world over, in fact, if you look at most of the nurses that are poached from Kenya because of the quality of production that we have. And we are also not talking about the quality. We are also talking about numbers, because we want to have human resources for health that are working in our country, and at the same time we have to export labor out there. Look at KMTC.
I'm looking at KMTC.
We have been moving. I'm coming back to your question.
Yeah.
We have been moving through leaps and bounds, from graduating a mere 10,000 up to graduating 24,000. And this year alone, we might be able to admit more than 28,000. Last year it was 28,000 students.
All right.
Now, going back to the quack doctors, I want to remind you of what happened to the facility that did an operation to somebody. And we were able to do a thorough investigation and close most of those facilities that are doing plastic surgery in the country. We have laws that already are governing that. So we are not doing guesswork. And anybody who does a shoddy job at any facility, they are able to be disciplined using the laws of Kenya. We have a Kenya Medical Dentist and Practitioners Council that is mandated to oversee the same. We also have other regulatory bodies that oversee different cadres. Okay. We have the Clinical Council, Clinical Officers Council, we have the Nursing Council, we have Nutritionists Council, we have many of all of them that are able to oversee and also be able to inspect facilities in case of some that have opened either without licenses or they do not have the proper human resources. Therefore, that is nothing, that should not be something to worry about in Kenya.
I liked that you said we look at KMTC. We are at KMTC, and that question, we're going to engage the audience here tonight. We'd want to hear what they have to say. And the question tonight also on our socials, we asked you if you had 30 seconds. And I repeat, if you had 30 seconds with Public Health Principal Secretary Mary Muthoni, what would you tell her? So we are here live at KMTC. We want to give our live audience an opportunity to participate. My first person to participate, just assist them with a mic. Pauline, kindly assist them with a mic. There he is. He's going to hold it for you. 30 seconds. Question to Madam.
Okay, thank you very much, Madam Pierce, for Public Health. My question is, how are KMTC students who are transitioning from the college, having graduated, awaiting employment, catered for under the Social Health Authority? Thank you.
All right. How are students who are transitioning catered for under SHA? You want to care to respond to that before we get another?
Yeah, sure. I want to guess that by the virtue that they do not have any income, under Social Health Authority, we have an option for indigents. They can register as indigents, or they can be catered for by their parents or a caregiver. And if you register as an indigent, then the government will pay for you. We are ensuring that each and every person in this country accesses health care and quality health care, just like what our Constitution says.
All right. Next question to our live audience. All right. Pauline, assist me here. Far end. Far end. The gentleman at the far end, just walk across. Remember, also you can be part of this conversation. Get us on our various social media platforms, including X at KBC Channel 1. What would you tell? P.S. Mary Muthoni is in charge of public health and professional standards. Let's go. The floor is yours.
I'm David Mereu, a student in Nairobi campus, and I just have a question concerning today's topic. And so, we being the students and the future workforce, sometimes we undergo financial constraints. So my question is, what is the progress of HELB allocation to KMTC students? Thank you.
Thank you for that question. Indeed, it is something that we have been pondering with. However, I know we have an allocation of 500 million already. I know initially it had been removed completely. And now we have an allocation of 500 million. We will continue supporting the same and advocating for the same to ensure that students of KMTC are equally catered for by HELB.
Any other question from the floor? The gentleman next to the lady.
Thank you so much, Madam PS. And I thank the opportunity to be a student at Nairobi KMTC pursuing medical engineering. You are talking about the training. And the training entails much. When we are in class, this part of curriculum that we cover in class. But the concern that I'm posing to the ministry now where you sit, that what is the ministry doing to support the students to access the clinical placement? Yes, we can be in class with theory, but now there's the concern of us going for placement for much practicals. In terms of site, we are able to access those placement platform without being charged, just for educational purposes. Thank you.
Placement.
I am aware that KMTC students are charged, and not just little money, quite a bit of money by facilities when they go for placement. And myself and the board of KMTC plus the CEO, we are working very hard. We are continuing to have conversation with these facilities so that they can lower those fees or scrape them completely, because at the same time you're learning and you're also offering services to these facilities. So I'm calling upon the facilities that house KMTC students to actually hear and heed to our call that they may remove the fees that are put for KMTC students or lower them at any given time. So we will continue talking to the facilities the owners of the facilities, the managers of the facilities, just to ensure KMT students have a seamless placement.
Very well said. Now we get online. We have two. I'm going to sample two. In the interest of time, there's so much that is coming in on our social medias platform, but you can keep sending them. We're going to share them with Madam PS. So one, he goes by the name Hillary MGL Hilarious. Well, all right. This is yes. I mean, they say SHA is not working. Secondly, Kamusi inayotembea. 30 seconds are much. I only need 5 seconds. I even don't earn any amount per month for me to pay 850 shillings in the name of SHA. In fact, pesa kidogo napata, familia inanitegemea. Let them sit and decide carefully. Young couples tunaumia kwa ground. Madam PS, respond to that too.
I've had, it's actually on the screen that SHA is not working.
Yeah,
but I want to say SHA is working. Please let us be specific. Let us be intentional. Let us say where SHA is not working, because that is the only way you can help us rectify. Indeed, I know there could be some places. For instance, we had facilities that are not contracted. If you don't have a contract with SHA, how is it going to work in your facility? And when somebody comes to that facility, you tell them SHA is not working. So we need the more than 5,000 facilities that are still out there and are not contracted with SHA, because that is where you will go to the to seek services, and then you're told pay in cash. Therefore, I would seek and plead with the members of the public that do not generalize anything about SHA. Come and say, I went to this facility, I was never treated, or I was treated and I did not like the treatment.
Right. Now, another comment online, someone is asking, now with the withdrawal of donor funding, will there still be free HIV and AIDS testing? VCT. Definitely anonymous.
Well, yes, with the withdrawal of the USG through the executive order, I know there's a bit of discomfort, there's a bit of restlessness, but I want to tell the members of public that to remain at ease. Already we have some of the commodities that have been reinstated. You saw the other day we got quite a number of commodities for HIV, TB, malaria. And again, we have not been told that it is forever. We were given 90 days. And we are still within those 90 days. And within the 90 days, a lot of things will have happened. I have said some commodities have been reinstated. As a government, we are also budgeting. We are working on our budgets, prioritizing some of the areas, getting other allies to come on board equally, other donors from other places. So there are many things that are happening already, and it is important that people to remain calm. We are still not at a crisis.
All right.
We have managed at whatever level.
All right.
Yeah.
Another question from the border counties. What is the status report, Madam PS, on the Kalaza outbreak? So far, over 20 of the children within my village have perished.
I am aware about Kalaza. In fact, most of my team members are in Wajir County, where Kalaza has really been bizarre, and it's really not been good, looking good. We have enhanced our surveillance on the ground. We have sent commodities. We have trained our healthcare workers on the ground, and it is a work in progress. There's a lot more that is happening on the ground, and we will keep this information coming. Should there be any alarm, then it can be raised either through the county government or through ourselves, so that we are able to manage the same. Also, procurement of other commodities is happening. Farm and non-farm beds, we have added more beds to those counties, and drugs at the same time.
I hope that puts them at ease. Now, as we work towards the end of this particular live broadcast, what is the department doing, to restore confidence in public healthcare? Over past it hasn't been so good, and that's the truth. What are you doing to regain confidence from Wanjiku?
Really, I don't know the degree of the confidence. I may not rate the magnitude of the confidence, because I would say it ranges from person to person, or from one area to the other. And just like I have told you, the kind of transformation and reforms that we have introduced in the Ministry of Health, it starts from there. Starts from anchoring everything into the law and ensuring that we are moving forward into implementing the same. And that is what we are doing with SHA. That is why I mentioned SHA is barely 2 years, whereas somebody would compare with another fund which had existed for 60 years and which was at the verge of collapse.
All right.
And again, we are also introducing programs that will help us go to the ground. We have a program that we call Epuka Uchafu Afya Nyumbani. Epuka Uchafu Afya Nyumbani basically talks about our personal hygiene, asking people to clean their hands. Just wash your hands at any given time. During COVID, you would sneeze and you wash your hands. You wave, you wash your hands. You would imagine that somebody has, you've gotten the germs by just waving at somebody. You would do anything. Touch on a seat, you wash your hands. What happened? So we want people to go back to that. Wash your hands at any given time, because the hand is one of your organs that can bring a lot of dirt to your body and to your mouth, whatever you swallow. Then even smaller children that are going to school, as little a thing as giving them a handkerchief, so that when they go to school, they are taught how to sneeze, taking care of the environment, environmental health and standards. I talked about climate change.
I'm there with climate change because I also want to know, in these projects, how are you involving, the counties in running these awareness and projects? Where do the counties come in?
There is nothing that we do without involving the counties. In fact, every of our programs and projects, for us, we come up with policies and training, while the counties are the implementers.
Good.
If you look at anything that we do, the counties are actually the implementers of anything that we come up with.
All right.
We can craft a program together, and then the implementation goes there. So I was talking about environmental hygiene again, teaching the people on how to stay better in their environment, draining water to prevent diseases like cholera, malaria. And we are just coming from a very successful project of distribution of 15 million long-lasting insecticide nets across 22 high-risk counties. Right. Clearing of bushes, basic things that may not cost you much. Then we also talk about water and sanitation. I cited that in this country, we still have 15 counties that practice open defecation.
Which are these counties? We'd want to know.
I may not have the whole listing, and let us
15 counties.
Let's not
open
name and shame
All right.
for now.
15 counties in the 21st century.
Let's not name and shame for now.
All right.
But we are working very closely with them,
counties,
so that they are able to up their game in terms of having everybody having a latrine or a toilet in their homestead, which is very important. Water, which is very critical. You either drink water that is boiled or is treated. Because should you not do that, then many diseases may come from that, and especially diseases like diarrhea, cholera, dysentery, and all that. So it is important for people to know what they can do themselves. Look at diseases like cancer. Many people are afraid of this disease, and they are saying it is a killer disease. But if we practice screening early, let's take, for instance, cervical cancer, we are practicing the 90-70-90 rule. 90% screening of all the women in the country, that we can achieve that. The 90% of all our women are screened every time. 70% vaccination, HPV vaccination to the young girls under the age of 14 years, and 90% of treatment. That should you get unwell, then we shall treat you. Right. So these are things that people must know. And we talked about communication, and you have repeated it, and people have said, we don't know. It's a challenge to me. I am a student of
I like that, because I'm about to ask you in 30 seconds, summarize public health. Remember the question we started with. I asked you to rate the public health docket between 1 and work in progress. Now, after we've talked about the 3 Ps and the projects, give us a figure so that we can track in the next 2.5 years where we will be at.
6 out of 10.
6 out of 10. That's around a B, B plus, B, B. B minus there above.
Kaizen.
We continuous
I
improvement.
believe in that.
All right. Parting shot, Madam PS. Parting shot. What is our take home tonight when you talk about public health and it delivering the dream that is universal health coverage?
This is the year of getting screened. Get to know your status at any given time. And I go back to prevention. What you can prevent, please do it to the very best. Promotion. If you get into your chama, please talk about the good practices, high levels of hygiene and protection where possible. The government is here to protect you, to ensure that our borders are free from harmful people and people who could be carrying viruses. So we will enhance our screening, enhance our surveillance, and ensure that our borders are free. Thank you.
Very well said. We have been speaking to none other than Principal Secretary in charge of Public Health and Professional Standards, coming to you live from the Kenya Medical Training College. This is a headquarters here. This is a parastatal that is under the Ministry of Health that is charged with the role of training professionals in this particular value chain for both the local, regional and international market on a night when we have been putting matters of public health into perspective. Take home the 3 Ps. What you can prevent, do. Go and promote it out there. As they say, prevention is better than cure. I'm Regina Manyara. You have been watching The Shift. Now I take you back to Broadcasting House.
By the time was too short.